femoral neck fractures, and these went on to require revision. 4 acetabular loosenings that required revision. 2 cup malpositions were not acceptable, and 1 femoral component that loosened as a result of avascular necrosis. Now, a couple of interesting things. The acetabular loosenings occurred in young patients. Femoral fractures, as you would expect, occurred in all older patients. Now, it's interesting because the weak-boned patients, the patients with a poor DEXA, had already been excluded. So there is something else going on apart from bone density, which affects the incidence of fractures. And the incidence of fractures is similar in both genders when you consider the fact that there were 5 times as many men as women in the patient group. There was no statistical significance between those groups. And infections affected mostly young men. All the infections were young men. Now, looking at this data further, we looked at femoral neck fracture versus body mass index. In the graph, the body mass index is on the horizontal line. The number of fractures, the incidence of fractures are the small triangles, and the number of patients in each body mass index group is in the bar graph below. There was no statistical significance relating body mass index and fractures, but we found, and the power was quite good. Now, looking at femoral neck fractures and T-scores, the thing that started us doing DEXA scores were these 2 patients here, which had hip resurfacing relatively early on in my experience and went on to fracture. After these group were excluded, then you can see a fairly steady incidence of fractures, irrespective really of the T-score level. So having excluded the weakest patient, say with a T-score of minus 2.0 and below, having excluded that group, then the T-score level doesn't offer any protective value as far as your patient selection criteria are concerned. So there was no statistical significance in this either, having excluded those weaker patients. Now, it was interesting that this is the graph looking at acetabular loosening. These are the instances of loosening. This is the BMI, and these are the bar graph is the incidence, the occurrence of the BMI, the number of patients at each level. There was no statistical significance, but I'm reluctant to accept that it's pure coincidence that of the 3 morbidly obese patients, 2 went on to dislocate, to have acetabular loosening. And now I would use a dysplasia cup for these patients and internally fix the cup. In terms of the classification, complications as they occur in surgical procedures are diverse and constantly evolving as techniques change. So if we're going to compare complications from one technique to another or from one prosthesis to another, another type of classification needs to be used. And I think the Dindo classification, modified somewhat, has benefits. The classification looks at complications on the basis of the remedial action required rather than the name of the complication itself. Our commonest complication was DVT, and that occurred in 2.3% of the patients. Our prophylaxis is, as you heard from Dennis, aspirin and early mobilization, compression stockings, but we use a stratified approach, and patients who have high risk of or have had previous problems with thromboembolic occurrences are treated as required with anticoagulants of varying potency. With improvements in instrumentation, the incidence of femoral neck notching without fracture has diminished from the 1.2% incidence. But as time went on, I took on more challenging cases such as epiphyseal slips and Perthes disease. The incidence of fracture was higher in the first 5 years of the series than in the second 5 years, but if those 2 initial patients are excluded and they would not have been operated on under current criteria, then the incidence would be the same. As expected, femoral neck fractures are more common in patients over 60, but it's interesting that having excluded the patients on the basis of their DEXA, the patients most at risk, femoral neck fractures still occur, and uncontrolled variables such as medications are, I suspect, are the cause, and some of the anti-cholesterol drugs can cause osteoporosis, and some of the antihypertensive drugs can interfere with bone metabolism. And a large proportion of the older patients are on those medications. Acetabular loosening occurred in patients under 60, and the obese patients, the morbidly obese patients, were overly represented in that age group, but statistically was not significant. So of the 86 complications in 840 procedures, 70%, 71% did not require any change in the program other than possibly oral medications. 1/4 of the complications required operative intervention, and 12% of the complications of the complications required removal of the prosthesis. But in all, 1.2% of the patients who started out with a hip resurfacing did not finish up with a hip resurfacing. Thank you very much.